Good evening, everybody. I'm Dr. Steve DeLuca, um, orthopedic surgeon here in Harrisburg, Pennsylvania. I've been in orthopedic practice for 18 years. A lot of my practice is focused on spine surgery. I got involved with TOPS back in 2016, 2017, and we did a 5-year study on the TOPS, 330 some patients. And I actually was fortunate enough to do the very first TOPS study patient in that study. And I actually did the last two patients. So there was about 37 sites across the country that were involved. And I did the first TOPS and I did the last TOPS in the study and a bunch in between. So I have, years of experience of TOPS, training other surgeons on how to do TOPS. And I see people quite regularly with questions related to TOPS. So that's really the focus of our talk tonight, is to introduce to you the concept of the motion preservation TOPS device, compare that to some traditional treatments, and then hopefully answer some questions for you. Now, I personally have just recently become a patient. So I am 2.5 weeks into a total knee replacement. The reason I'm an orthopedic surgeon is because I had surgery on my knee when I was 16. So I had very many frequent visits to the orthopedic doctor from, probably starting in about 12, 13 years, through my collegiate and medical school days. So became very familiar with my orthopedic surgeons and just kind of got interested in that way. So about 2.5 weeks ago, I had surgery. And as a patient, it was very different being on the other side. I also had many fears and concerns and believe it or not, questions, just like a lot of you might have. I also had pain. Pain is real. Everyone's pain is different, but learning how to deal with and cope with the pain I was experiencing before and again after surgery was something new to me. I need to be compliant. I need to listen to what the doctors and therapists are telling me. I need to make sure that I'm not overdoing things. That's always a big concern. And then when I am doing things, I need to be sure I'm doing the right things. I have to do my physical therapy, I have to do my home exercises in between. And most importantly, I have to give my body time to heal. And nowadays we're very impatient. We want things to get better quicker. I'm trying to get back to work as fast as I can, but my body's telling me, listen, this is what we have to do to get better. So it's always great when a doctor is also a patient, because it really does kind of make us better doctors, even though I try to approach each and every patient with the same compassion that I would think that they would have with that condition. I now have had, knee replacement surgery, and many of you may have had as well. So it's been a quite an eye-opening experience. Now, regarding TOPS, we're going to switch gears and we're going to talk about the back. So again, and one of the things we could do is we could go through a bunch of slides, or I could just talk to you folks like you were in my office, and this is how I talk to the patients in my office. This is a model of the lumbar spine. So the TOPS device is not for your neck. It's not for your upper back. It's just for your low back. And it's the bottom part of your low back. If we look at this full spine model, again, it's not for the neck or the upper back. It's for the lower back. And it's not for the bottom level. It's not for the L5S1 level. That level is not a candidate for TOPS. Okay. That level, if that level does develop a surgical problem, usually that's always fusion. Okay. We're talking about L4-5, which is the level that most commonly goes bad, sometimes L3-4, very infrequently L2-3. And when we talk about the problem, there's a couple of different problems that can develop in the back. Um, and these problems can cause things like what sort of symptoms would you have? Well, back pain, of course, but you'd also maybe experiencing leg symptoms, pain, numbness, tingling, traveling down one or both legs. Sometimes it's, a little more inconspicuous than that. Sometimes it's like, well, my legs don't have pain, numbness, tingling, traveling, but when I stand or walk too long, I get a heaviness or a burning in my legs, and then I have to sit down and wait or lean forward. I can, it feels better, then I can walk a little bit further. We call that symptom neurogenic claudication. When you walk, you have to stop and lean forward or sit. That's called neurogenic claudication, and that's the result of what's called spinal stenosis. Your spinal cord here in the middle gets trapped like this and squeezed, and when you go to walk, the muscles in your legs can't get the nerve flow they need for you to continue to walk and get those muscles that are responsible for walking the nerve flow they need. It's analogous to stepping on a garden hose. The garden hose delivers water to the flowers. When you step on that garden hose, you're decreasing the amount of water that gets down to those flowers. And if you are increasing the demand you need on your muscles and you can only get that little bit of flow down to those flowers, well, then you're going to develop neurogenic claudication, pain, burning in your legs when you walk or stand too long, got to sit and lean forward. When a nerve gets entrapped, okay, when a nerve gets entrapped, this is a nerve coming out of nerve hole. The nerve hole we call the foramen. The nerve gets trapped and it sends signals down your leg. We call that radiculopathy. It radiates from your back down your leg. Sometimes we call that sciatica. Now, sciatica actually is a similar but different condition that starts in the buttocks and it's actually outside the spine and it goes down the leg. So, one of the things we have to do as doctors is differentiate if you're having this radiating pain down one leg, is it coming from your back or is it coming from sciatica? And we can usually tell that by x-rays and MRIs. So back pain, leg pain, numbness, tingling, burning, difficult when you stand and walk. And when we're specifically talking about the degeneration that occurs in the back. Degeneration is arthritis. I had degenerative arthritis in my knee. Okay, the cartilage wore out to the point it was bone on bone. That can happen in the spine as well. Most commonly, patients develop a condition called degenerative disc disease, where the disc, which is a jelly donut, eventually starts to flatten like a pancake and it loses its water content and it flattens. And that's called a degenerative disc. Okay. So if you've been diagnosed with degenerative disc disease, that's what they're basically telling you is that the disc is no longer a jelly donut. It's flattening and it's becoming a pancake, and the disc is flattening and the bones are becoming, near bone on bone. The reason that's important is because that can decrease the height of the nerve hole and that nerve can get pinched. I always tell patients that their nerve hole is completely dependent on the height of the disc. The higher, healthier the disc is, the larger the nerve hole. The disc degenerates and narrows, so does the nerve hole, and then all of a sudden the nerve gets pinched and you get radiculopathy. A degenerative disc is not a candidate for a TOPS. The TOPS device actually requires a good disc. What happens in a TOPS device, when patients are good candidates for that, it actually occurs in the joints of the back. These joints are called the facet joints, okay? These joints are just like little tiny hips and little tiny knees. There's two sides to the joint, one side here, one side here. There's cartilage in between. There's fluid in the joint, just like in your knee or your hip or shoulder. And just like any other joint in the body, that cartilage can wear out and it can get arthritis to it, okay? So when these facet joints get arthritis to them, they start a degenerative process which squeezes the spinal cord from the back and causes that spinal stenosis we were talking about, where the spinal cord gets pinched. Okay. Now, the other thing that can happen is that you can develop a little bit of what's called instability of the spine, where the bones should be stacked one on top of another, but one bone starts to slip forward on top of the other. That's technically called a spondylolisthesis. That's a fancy name for one bone slipping on top of another. So these bones here in this spine model are all lined up one on top of another. But if this bone were to slip forward on top of this bone, that would be called a spondylolisthesis. And that's a degenerative condition that's quite common. Now, when that happens, the body says we have to stabilize that and keep it from slipping forward. So these arthritic joints get bigger and the soft tissues around them get thicker, and they're trying to keep that from moving. And guess what that does? That presses on your spinal cord and spinal nerves even more. And then you get lumbar spinal stenosis, neurogenic claudication, lumbar radiculopathy. So that's where the treatment comes in, okay? If your disc is degenerative and it's gone from a donut to a pancake, then that requires fusion, okay? Because the TOPS device replaces the facet joint. Basically, we replace the facet joint with screws and this TOPS device, which I'll show you in a minute here. But just to talk about the treatment. So lumbar laminectomy is the traditional treatment for spinal stenosis. Basically, this is called the lumbar lamina, here, right here, right here, right here. And traditionally, the oldest operation we have is to go in and do a laminectomy, where we remove the lamina, both sides. We take out this bone called the spinous process, and we find the underlying spinal cord and spinal nerves, and we free those up so that patients can stand and walk better. Okay. Now, if a patient has instability, after we take the lamina out, that instability where the bones are slipping is going to get worse. So traditionally, what we do is we put pedicle screws in, and we would put a rod to connect them, and we would fuse that segment. Okay, so that segment won't slip or move anymore. So again, the number one goal of the operation is to decompress the spinal canal with the laminectomy, free up the nerves in the foramen, and then stabilize the slip so patients don't have that ongoing pain from that forward slippage. Okay, and that's a lumbar fusion. This is a lumbar fusion. Okay, these are pedicle screws here and here. This is looking at it from the back. From the side, the pedicle screws are in the bone, and there's a rod that connects them. Okay, there's one on each side. There's a screw on each side with a connecting rod, and that's called a lumbar fusion. Okay. Um, if your disc is healthy, okay, you do not have a degenerative disc, but you do have degenerative spondylolisthesis, you have arthritis in the facet joints, sometimes called spondylosis or facet arthropathy, basically arthritis in the facet joints, and it's pressing on your spinal cord and spinal nerves. After we go in and we do our laminectomy, we put our screws in. Instead of putting a rod in, we put this mobile device in, okay? And the TOPS device is this device here. Again, the screws are in the bone, just like in the fusion, but instead of a connecting rod, you have this mobile device. Okay, this mobile device is this device here. It's made out of two pieces of metal here and here, and then this polyurethane, which we actually fill with saline, and that actually becomes the mobile portion of the device. Now, a normal spine, okay, a normal spine will have several different motions it can do. Obviously, when you bend forward and backwards, it bends forward and backward. We call that flexion extension. It will also rotate, okay, so we have flexion extension, rotation right and left, and then it will side bend. So you'll bend to the right and you'll bend to the left. Those are the natural motions of the lumbar spine. When we do fusion, we eliminate all of that motion, okay? So we fuse that segment so that's no longer going to move. And yes, that puts a little bit of stress at the levels above and the level below that fusion. And those levels now see increased force and increased stress, and they have a little bit higher propensity to develop arthritis in them compared to if they didn't have the fusion. Now, with the TOPS device is the only device that's been made that actually mimics the normal functional anatomy of the spine, meaning that it will side bend, okay, it will side bend, it will rotate, and it will allow for flexion and extension. Okay, so it actually is a facet replacement. Okay, I just had my knee replaced. They replaced both sides of the joint with metal, and plastic. This facet joint that I described earlier is now being replaced by this here, the TOPS device, which acts exactly like the facet joint. It has the same motions of as the facet joint, and it preserves the more normal motion of the spine. So that's really the benefit, okay, is that it preserves the motion. And again, it's not a disc replacement. A disc replacement is when we replace the disc to preserve motion. The TOPS device, you have to have a good, healthy disc, okay? And then you're a candidate for the TOPS device. Now, there are some contraindications to the TOPS device. Okay. Most commonly, we see the disc is too degenerative. So we do have radiographic and MRI criteria that the disc has to be healthy enough. You can't have a herniated disc. Okay. That's an early sign that the disc is going to go bad. A herniation is like the disc is a jelly donut. A herniation is it squirted some jelly out of the donut and now it's into your spinal canal. That's the sign of an early degenerative disc. So you can't have a disc herniation. You have to have a good enough healthy disc because again, we're going to use that disc afterwards. You can't have too many levels of degeneration around the TOPS device. So if you have horrible disc above here and up here and down here, and that, that you're not a candidate for the TOPS. You cannot have a condition called scoliosis. Scoliosis is when we're looking at the spine straight on and someone gets a curvature, okay? So if you get a bad curvature in your back, you can't have the TOPS device. The TOPS device can only be done if you have minimal to no scoliosis. If the bone is weak from osteoporosis, then you can't. We can't do the TOPS device because we're putting screws into the bone, and the screws I always describe as like the screws are like kind of putting like a fence post in the mud. So we want to make sure that when we put that screw in that bone, it's not a fence post in the mud. It's got solid foundation to it. So osteoporosis won't allow that screw to really get good enough fixation. So osteoporosis, and if you're not sure, we get a DEXA scan, and a DEXA scan we have criteria to see if there's too much osteoporosis. Obesity, if your BMI is over 40, then you're not a candidate for the TOPS device. If you've had a fracture, okay, sometimes fractures are not treated with this. They're treated with other means of surgery if you need to have surgery for fracture. And then the other important thing is we don't treat back surgery. I'm sorry, we don't treat back pain with back surgery. Back pain is difficult to fix reliably with any sort of back operation. Yes, back pain is one of the symptoms most people present with, but we can really fix for you with back surgery leg symptoms, pain, numbness, tingling, radiculopathy, neurogenic claudication, difficulty standing, walking because of leg symptoms. Those are the symptoms that are very reliably fixed with back surgery, and in particular the TOPS device. And the TOPS device will preserve that motion at the level we're operating on. Now, some patients have developed a bad disc at 5-1, so their L5S1 develops a degenerative disc problem, and then they have a degenerative spondylolisthesis at L4-5 with a healthy disc. So I also was the first one in the country to do a fusion at 5-1 and connect it to a TOPS at 4-5. So that's actually a very good indication for the TOPS, is if someone has needs a fusion at 5-1, because again, we can't do TOPS device there, and they have the degenerative spondylolisthesis with a good healthy disc at 4-5, we can do the TOPS device, and I just put 2 more screws down at S1 and a little connecting rod that connects the screws at 5 and 1 together. So yes, there are some people who can get a combination fusion TOPS device. And again, TOPS is not for everyone. I would say that probably about 10% of patients I see would be candidates for TOPS because the criteria is quite specific. And again, that's what you're going to have to talk to your surgeon about when you see a surgeon regarding a TOPS consultation. The most important question is, am I a candidate? Do I have the right symptoms? And do I fit the right criteria to benefit from the TOPS device? So then let's talk about why the TOPS device is good. So in the study that we did, it's a 5-year study. We have most of the data we have all the data for the first 2 years, and we're now starting to get most of the data for the first 3 years. But the 2-year data has clearly told us that TOPS patients get better. Let me tell you about the study first of all. So in the study, we had, for every 3 patients we had, 2 people had the TOPS device, 1 person got a fusion. Okay, now keep in mind, fusion is still gold standard. You go to anybody else in the country with this problem, they're going to give you a fusion. Okay, so the TOPS device, we were looking to see, will it perform as well as or better than the fusion? Okay, and what we found was, compared to the 1/3 of the patients who got the fusion, the 2/3 of the patient with the TOPS device, they did better faster than the fusions, and they maintained that improvement long term. Okay, so when I would see somebody back from the TOPS device, they were doing very well very quickly. My fusion patients would take about 6 months to kind of catch up, and that's not uncommon. The fusion takes about a year and a half to completely fuse. Because it's a fusion, you can't bend and twist and do things after surgery. You have to have a back brace. We don't let you move or bend too much. You can't take any anti-inflammatories after fusion. TOPS device, maybe a brace for comfort, but in general, you can start moving it right away. You want to take some Advil or leave, you can do so. It's not a fusion, so we don't have to worry about, not fusing because you're taking too many anti-inflammatories. So what I found and what we found was that the TOPS device was doing better faster. Then when we looked at overall at the 2-year mark, what we found was that when we looked at patients' complaints of back pain, when we looked at their ability to do things, we call that the Oswestry Disability Index. When we looked at the ODIs and the VAS, are you having pain? What number? ODI, what sort of things can you do? And then we looked at the motion of the back on x-ray, how they bend and forward bend and side bend and twist and things. And then we looked to see if they had any sort of, new neurologic complaints. Are you having any new pain, numbness, tingling? Across the board for all 4 of those criteria, TOPS did better, significantly better, to the point that overall TOPS patients had an 85% good to excellent result compared to 64% for the fusion. Now, the other part of the hypothesis is that long term, because we're preserving motion, is that hopefully the discs above and the disc below won't develop arthritis as quickly. But that's going to take us a long time to kind of figure out if that's going to be the case. But with the new neurologic symptoms, that's kind of a hint that the TOPS patients are not developing those, whereas the fusion patients may be. So when we looked at the lower extremity symptoms, did patients get relief of radiculopathy and neurogenic claudication? Yes, across the board with both fusion and with TOPS, patients did equally as well. Reoperation rate, how many people had to go back for problems with a fusion or a TOPS, was also very equal. So the things that were significantly better were back pain was better, their disability was better. They didn't have as many new neurologic complaints with the TOPS device, and their lumbar motion did what we wanted it to do. The TOPS preserved a more normal motion. Those things were across the board better with the TOPS device. So that's really, what I wanted to express to all of you. Again, just to recap, the TOPS device, the TOPS stands for total posterior stabilization device. So it's a stabilizing device that's allowing motion. What it's doing is replacing the facet joint. The facet joint is the joint in the back that moves in the back and it moves with a healthy disc. When that joint gets arthritic, it can put pressure on your spinal cord and spinal nerves. It can cause lumbar spinal stenosis and neurogenic claudication. It can pinch on the nerves and cause lower extremity symptoms called radiculopathy. The treatment for that, if you're a good candidate, could be the TOPS device. If you have one of the contraindications, most commonly is to degenerative a disc, well, then it would be a fusion. And in some cases, we can do a TOPS on top of a fusion. So those were really the things I wanted to express to all of you. And at this point, I'd like to open up, the field for any sort of questions you all may have.
And Dr. DeLuca, I have a ton of questions that have been sent in, so I'm going to fire them at you, okay?
Go ahead, please.
So the first one is, what do you think about the longevity of the components of TOPS over 20 years, even though we know we don't have 20 years? What is your thought?
That's an excellent question. So there's 2 answers to that. One answer is the TOPS device is not a novel device. We actually had the device here in the early 2000s. They did implant a bunch of the devices. One of the doctors on the current study that we did, he was on the first study, Dr. Dom Courage, and he had excellent results. But the study just didn't get off the ground when they redesigned the study that we just did back in 2017. It was a much better study, so we're going to be able to get those long-term results. But Dr. Courage actually sees quite a few patients back, and anecdotally, he's reported excellent results long-term, 10, 15, 20 years. The more reliable data comes from Europe. They've been using this device in Europe for 15 to 20 years now with excellent results. There has not been a lot of reoperations on the device. The device is titanium. Titanium is the metal that your body likes. Has the stiffness closest to bone of any other metal, so your body likes that. And the other question I often get is like, well, what happens if you do have to go in and say the disc does go bad with time, or something happens and you have to fuse the tops? Like, what happens then? Well, it's actually technically from the surgical standpoint, not that complicated of an operation. All we do is go in and remove this part of the device. The screws stay where they are, and then we just put the rods to connect the screws that are already in there, and then we put bone graft in there and fuse it. So the bailout, when as a surgeon, we always think, okay, what's the worst case scenario, right? I plan for the worst and hope for the best, and we do our best job. But the worst case scenario is if this TOPS device were to need to come out and be fused for whatever reason, well, we just take the device out, we leave the screws, and we just put the rod across and fuse it. So not a bad option if you had to do that. Now, in the 25, 30, 40 patients that I've done, knock on wood, say my orthopedic prayers, I've not had to go in and revise any sort of TOPS for any reasons. But if I did, that would be the process. But the overall results in Europe have been very good long-term for TOPS.
And so another question for you too is what is the post-op regimen? When can I go back to work, get back to activities, that kind of thing?
Yeah, and that's a great question. Again, as someone who just had surgery 2.5 weeks ago, that's a great question because everybody's different, right? I can tell you that at the 2-week visit, my TOPS patients look like they've had surgery like 3 months ago, meaning that their pain is minimal. They're taking Tylenol, Advil, Aleve. They're up moving and walking already. They're starting to do bending and twisting activities where a fusion, you're not allowed to do that. Okay, I use a back brace for 2 to 3 months afterwards. Careful how you bend, lift, and twist. No Advil, so it's Tylenol, pain medications. So fusions do tend to come in and kind of it takes some months to get better, whereas TOPS is kind of better within weeks. Not for everybody, but most patients. The other caveat to that is when patients are doing very well very quickly, we just have to remind them to not overdo it. So depending on the type of work you have, and everybody's work is different, if you have a sitting desk type job where you can get up and move around a little bit, within a couple weeks, you might be able to get back to doing that. Maybe you can work from home, maybe go to work for a few hours, a couple days a week, and just kind of gradually get back into it. Say you have to do a lot of bending, lifting, twisting at work. Well, yeah, I'm not going to let you get back to work lifting 50 pounds 2 weeks after surgery. But it's a gradual progression back to getting back to normal activity. So it really depends upon the type of work you're doing. But I would tell you certainly that patients that have a more physical job, I would still tell you, listen, your body still needs that time to let you recover. Now, the immediate surgery, it's exactly the same. The time to do the operation is the same. We usually put a drain tube in at the end of the operation. We keep you in the hospital for a day. We pull the drain out the next morning and go home the next day. So the hospitalization, the surgical time, the complications, and everything from surgery are exactly the same. But the TOPS patients do get better faster. And again, you still have to let your body heal before you can get to full unrestricted activity. But the TOPS patients are getting back to full activity a little bit faster.
Another quick question. One of the participants in the webinar had a laminectomy a couple of years ago. Did not fix the leg pain and the leg numbness and pain. Would he or she still be a candidate for TOPS?
So yeah, excellent question. For the study, anybody who had previous surgery was automatically eliminated. But after the study, now that the device is available commercially, now that we know the device outperformed fusion, the FDA actually came to us and said, hey, this device is doing great. We don't need to see all the 5-year data. You guys can start putting this in patients because it's that good of a device. So outside of the study, yes, if you've had previous surgery, that is not a contraindication. You could still benefit from TOPS as long as you meet the other criteria we talked about. As long as the disc is still good and healthy. And that's really the main thing that we see when we talk about fusion versus TOPS is the quality of that disc. But yes, you still may be a candidate. You'd obviously have to see your surgeon or a TOPS surgeon and see if you fit the criteria.
Next one, what is the maximum allowed level for slippage during flexion extension for TOPS? This person actually has 10 to 12 millimeters of slip.
That's a great question as well. So we grade the forward slippage 1 through 4. Okay. So the more severe the slippage, the more you're going to need fusion. So 10 to 12 millimeters is probably on the upper limit of a grade 1, maybe a mild grade 2. But that could still benefit from TOPS as long as the disc is good and healthy and as long as the other criteria are met. So sometimes when you get too big of a slip, then you start to develop a disc problem, and then and that's the reason why too high of a slip isn't a candidate, is because the disc goes bad. So I've done slips of 10 to 12 millimeters before with a good healthy disc, and the TOPS device, we're not really using the TOPS device to correct the slippage, but when we do the TOPS device, it does correct some of that slippage back. So that's the other thing. We're not really, using the device as a deformity correction, which can happen when you get to grade 2s and above. You really need to have that corrected. So grade 1 slips, grade 1 degenerative spondylolisthesis is really what we're looking for. So 10 to 12 is right on the bubble. We'd have to take a look at that disc.
So I'm going to combine a couple of questions. One, does full activity, when I can be full activity, does it include potentially playing golf, and or
Yes.
will I be able to lift my kids? That
Yes.
kind of thing. And I'm assuming I don't think your kids would want to weigh 150 pounds, Dr. DeLuca.
No. So the answer to golf is absolutely. Probably, depending if you're doing well, golf could be 3 months. Lifting, again, when you get to about 6 months, I don't really have any restriction on you after TOPS. I do recommend careful how you bend, lift, and twist, but there's not really a long-term weightlifting restriction. Same thing with fusion. Fusion, those same restrictions are going to be pushed off a little bit longer. At 6 months, I'm still kind of cautious. I'm still cautious with people when they have fusion on how they lift and how much they lift. But maybe 50 pounds at 6 months. But with TOPS, I really don't have any significant restrictions at 6 months. You can pretty much do whatever you want to do.
Well, I hate to say it, but we are out of time, Dr. DeLuca. Thank you so much. And for those of you who sent in your questions, which I have a lot of them, many of them that I did not ask were really in-depth questions about whether I'm a candidate, what they think their pathologies are. And I think, based on the fact we don't have time to walk through that, if you do want to speak with someone in your area that is using TOPS and has experience with TOPS, please contact Shelby George, whose contact information is there. And if you're in the Pennsylvania area, please contact Dr. DeLuca directly. He's near Harrisburg, as we described, and be happy to talk with you with no questions. So, Dr. DeLuca, surely appreciate your time. Thank you. Appreciate it very much. And those of you who attended, thank you for your time, and reach out if we can be of any assistance. Thank you.
Yes, sir. Yep.
Go ahead.
I encourage everybody to reach out. We're very happy to answer questions and direct you to a surgeon through Shelburne. We'd be very happy to do that for you.
Perfect. Thank you. Everyone have a nice evening.
Thank you.